Hi, everybody. I'm Dr. Keith Darrow, and I am very excited to welcome an international guest to our podcast today. Today, we have Suzana Matalqah, who is in Jordan. And I'm so excited to learn what audiology looks like internationally, right? I've been to South Africa. I've worked with people over in Europe, but I have to say, Jordan, this is a first for me. So I'm very excited to have you here. Thank you.
Hello, Dr. Darren. Hello, everybody. I am really honored to be here with you in this podcast or video or wherever it's going to be.
It'll be everywhere. Don't worry. We'll get it on iTunes. We'll get it on YouTube. Everybody will be able to see us and hear us. So I guess really my first question is, how do you get into audiology, right? I can't even imagine what your sort of school system looks like, how you end up going down the path of audiology. And then, I know you went to the UK for a little bit. So tell us a little bit about your story.
Okay, so to answer your first question, you get into audiology by getting your bachelor's degree in audiology and speech pathology, and then you choose whether you're going to finish in audiology or speech pathology.
All right, so not that different. Okay,
yeah, easy.
Gotcha. All right, okay.
Then I finished my master's degree in the UK, but you don't have to finish your master's or to get a master's in order to work as an audiologist here in Jordan. I don't think it's going to make much of a difference here, but it allows you to open your own clinic because you cannot open a clinic unless you have a master's degree or maybe an ENT doctor that would open it for you.
Interesting. So your motivation, even early on, was to get into private practice and open a clinic.
Definitely.
Now, why would you do such a crazy thing? Don't get me wrong. I love it too, and I do it. But, we're a special, crazy bunch of people who say, I want to go all in, open a clinic. Like, what was that like for you, and why'd you do it?
I think audiology is not perceived or is not how it should be here in Jordan. I get it. It's growing up really quickly, and people are starting to know how good it is to treat your patients well, give the best services, and do all these scheduling follow-ups and do the fittings properly. But I don't think it's as it's supposed to be. I want to make a difference. I want to give the patients what they deserve, fit the best hearing aids for our patients, pediatrics, elderly, all these people.
So are you a multi-specialty site? Are you working with children and adults?
Oh, yeah.
Are you doing balance? Are you doing auditory processing? What is it you specialize in?
We don't specialize in Jordan. If you are an audiologist, you do it all. You do the testing, you do the fitting, you do the reports for the doctors, all this stuff. Vestibular is a little bit hard, so I'm gonna need a course, or I'm gonna need to be more educated in it in order to open my vestibular business. But I'm looking forward to it.
Oh, that's exciting. So, all right, you definitely you pulled at my heartstrings there when you said you wanted to open a clinic and you wanted to be different. What does that look like for you? What does it mean to be different? Because look, I'm going to level with you, Suzana. A lot of people say that. And when you go through their patient journey, when you call the office, when you go in, turns out a lot of things end up being the same. So what does different mean for you, and how have you increased your value to your patients?
Okay, so here in Jordan, you have a hearing loss. You go to the ENT doctor. He sends you to an audiologist. The audiologist do the testing, send you back to the ENT doctor. The ENT specialist decides whether you're going to be fitting hearing aids, you're going to be taking medications or vitamins sometimes in order to get rid of that hearing aids, as they say. It's starting to become better these days, but my aim is to let people know what an audiologist is supposed to do. He's supposed to do the testing. He's supposed to make the call whether you're going to need to be treated or you're going to be taking the medications for the sudden sensorineural hearing loss or all the other conductive hearing losses. I want the audiologists to know how important they are and how much impact they have on the patient.
Now,
Our ENT doctors are gorgeous. I agree. We need to work together. We're not canceling them. Don't get me wrong.
well, I guess so. I mean, look, that's a very interesting model. I think that's how a lot of audiology across the globe sort of starts out. But how do you, I don't want to get too controversial, but the statistics tell us that less than 5% of people with hearing loss need medical intervention, meaning surgery or medication. So it's interesting that you have to send 100% of your patients to the ENT for approval when only 5% of them ever need to see an ENT. I mean, again, I don't want to get too political or controversial, but it seems like we're wasting a lot of time.
Yep. Yep.
Okay. Yep. That's it.
I'm not. No, I'm not. I'm not blaming the ENT doctors. I'm mostly blaming how educated the patients are, because a patient will not fully trust you. He needs a doctor to tell him, "You go get your hearing
Okay.
aids."
Okay. Now
Exactly.
that I can understand if that is sort of the culture of right, patients don't really make decisions without consultation of their, doctor, medical doctor, then okay, that fine. I mean, I guess right. That's why we're on this mission to change that impression because we're not just technicians. We're not just pushing buttons, putting hearing aids in people's ears. We're really providing transformative treatment for hearing loss and tinnitus. But it's an interesting system, and I'm excited to learn about it. And have you made much progress with ENTs? What's that relationship like for you?
It's been going really well. I've been in the business for like 6 months only.
Okay.
And I've been really seeing so much acceptance from the ENT specialists. They are not so against it. They love getting reports from us audiologists telling them what the issue is, where to look at, and how to get it treated.
Mm.
And for the patients, if you make them believe that you know what you're talking about, they're gonna listen.
Okay. That's fair. So tell me a little bit about what does treatment look like in Suzana's clinic so that it's not just another audiology clinic, right? I know that you specialize in treating hearing loss. I know that you have, your way of looking at and managing the patient with tinnitus. Like, tell us more what that looks like for you and somebody who's opening a new clinic.
Okay, so first you're gonna need to do all these tests, the PTA, the tympano, to know exactly where the problem is, or to know if hearing aid is the only solution. Because you don't want to risk losing the chance of treating it if it's, like we said, a sudden sensory neural hearing loss that could be treated, or you just need to know where it begins from, or maybe it needs a CT scan in order to see if it's more than hearing loss. So when we're done with all these tests, when we know exactly where the issue is, we either send them to the ENT specialist or we start with the hearing aids. It is the hardest part to convince your patients to wear the hearing aids, but you know it. It's universal.
Hey, that's a global
They do
problem.
not like it. Yeah, they do not like it.
Yeah. I'm just curious, how does it work in Jordan? Is it part of government insurance or is it pay out of pocket like in the States?
It's pay out of pocket.
Okay. Because here's the deal, right? And I know you know this, but people in the United States will always tell me, oh, my patient didn't start treatment because of the cost. Everybody argues cost. Well, my and in the United States, at least, the average treatment rate hovers around 35%, right? So that means 35 out of every 100 patients, or let me flip it, 65 out of every 100 patients that walk into the clinic say no to treatment. And audiologists insist that it's cost. Yet when you go to first world countries where they have insurance, like Denmark, like, Canada, like UK, and they cover the cost, they don't seem to help a lot more people than we do. And so I think, and you'd probably agree, it's not always really about cost. Are there people that can't afford it? Yes. But I think ultimately it boils down to the value and why it's so important to treat your hearing loss and to use your prescriptive hearing aid technology. And so how do you convey that message? What's your value proposition to the patient to say you got to do this?
I begin with, I don't want the cost to be our issue. I don't want the cost to be why you're getting only one hearing aid, not two. We can do installments. I can get you a good deal. We can work around this. I need you to get treated because, the dementia, the tinnitus, the memory, the attention deficit, the depression. They didn't get their hearing loss 2 days ago. They've had it for like 4 years when they came here. They're depressed. Yeah. They don't meet people as much. Their grandkids, they don't sit with them as much. So we need to fix these stuff. And most of the time, I ask the patient to come with someone because these significant other or their kids, they know the issue. They would say, my mom has hearing loss. We struggle with 1, 2, 3, 4. So when the patient sees that the other people are also struggling with them, they need to get help.
Absolutely. I mean, it really is. It's such, look, we've been, even through the World Health Organization, I believe that we have been greatly underestimating the impact of hearing loss and tinnitus, right? If you look at some of the data that's out there, they estimate 10 or 15 or 20%, yet a paper just came out this year out of Columbia University and said, if you measure hearing loss differently, if you abandon the traditional ways of measuring it and pure tone average, and if you classify it using this technique, well, it turns out that almost 77, nearly 80% of adults over the age of 35 have significant hearing loss, right? It's like the total opposite. And so maybe the number is somewhere in between, but the problem is so much bigger than I think we accept. And by we, I mean the public at large, the medical community, the insurance companies. And is that something that you see in Jordan also, where people just sort of minimize hearing loss?
Definitely. I once mentioned that hearing loss is, I forgot to tell you that my dad is an ENT specialist, so we get on these debates most of the time. So,
Okay.
So I once mentioned that hearing loss is contributes to memory loss and attention deficit and all this stuff. So one of my dad's friends was like, "Oh God, it's just hearing loss. Stop." So they don't understand. They don't understand that it is bigger than it seems.
I always say while I was at Harvard Medical School, I took it was this advanced neuroscience class, and I was the one research student. Everybody else was going on to become a medical doctor. And I swear I was in there one hearing lecture, and it was 1 week, met for 4 hours, and that was it. That was all they ever learned about hearing. So it's like, I don't necessarily blame them, right? Like, they got to cover the whole body. So they can't spend months and months and months just thinking about the ear. But hopefully they'll listen to us a little bit more and listen to the research that clearly finds treating hearing loss reduces the risk of cognitive decline. It treating hearing loss and tinnitus properly can help make the ringing, be reduced, if not go away, and really improve quality of life and reduce the risk of falls. And there's so many great benefits to it.
Definitely. You know what's the best part about being an audiologist? It's when your patient comes to you and tells you that I have tinnitus and I cannot bear with it. I'm going to kill myself. And then you set them down, you fit them with the proper hearing aids, and it's gone. It's hearing the tinnitus is gone just by activating the hearing aid. And they look at their husband or their significant other and they're like, I cannot hear it. It's not there. And then in the follow-up, the scheduled follow-up after 2 weeks, they come to you and they're like, I can sleep properly. I can go with my friends, and they're so happy. It's my favorite part.
It's amazing. It really is. And that's why I always use the word transformational. It's not just hearing aids. It's not even just treatment. It is life-changing. It's transformational. And you're right. That is the single most rewarding part of this job, especially those patients who are in so much pain, because people don't associate hearing loss with pain. But tinnitus is painful. It's emotionally painful. It can be physically painful for some people. And we have the ability to reduce that, right? Amazing paper. Stéphane Maison, dear friend of mine, just published a paper that confirms what we've been saying for years, which is tinnitus in the vast majority of people is the result of a breakdown in the cochlea and the neural connections from ear to brain. Thus, treating it with sound stimulation, providing that biological feedback, has a significant effect on the system and can train away the tinnitus. And you know, I'm not suggesting it's perfect, but pretty darn good.
Yeah, it is. It is. The only issue now is that it only helps 60% of patients with tinnitus. So I'm hoping we can figure out something for the rest of 40%.
Well, I'll tell you this, and we can talk more offline. The systems that we've created in our practice has gotten us between 85 and 90% successful treatment rates, right? We have our sort of 6-step tinnitus treatment program that we've had a lot of success with. Much of it is based on what has been coming out in the research literature. But you're right, though, we're always going to be left with some people who don't get the help they need. And that's when, you know, cognitive behavioral therapy, it's brand new. So I'm not promoting it necessarily, but there's the brand new bimodal stimulation where you shock the tongue and listen to it, right? Just retraining the nervous system. I think that we have to, you're right, keep working towards, if we can get that number to 100%, that would be even better.
Yeah, hopefully.
So what else do you see that are some of the differences? Because you have been in Jordan, the UK, you're starting to learn about US audiology. What more are some of the differences you see? Or maybe what are some of the similarities that gives you hope that, right, there's this international movement to improve hearing healthcare?
Okay, so one thing I've noticed about audiology in general, I thought it was only in Jordan, but when I went to the UK and see all the private clinics, I found that it is a lucrative business venture for most people. They only care about the money. They only care about selling the hearing aids. They don't care if their patients fit like well, or if they need the extra number of channels, if they don't. They don't care about scheduling a follow-up. It's here. I can see it in Jordan. I can see it other places. But I'm happy that we're starting to get away from that. I'm happy that we have some clinics that do proper hearing aid services, audiology services, and all these follow-ups. I'm obsessed with scheduling follow-ups. I want to know. I want to know that my patient is wearing these hearing aids. It's not in a drawer in their closet. It's in their ears.
Good for you. Good for you. That is excellent. Suzana, look, I want to stop right there. I think that this has been an excellent interview. I've got to learn so much about you, about how you practice, about a little bit about what audiology looks like internationally. In Jordan, you're the first true Jordanian that I have met. And so thank you for taking time out of your schedule, because I know we've got quite a time difference. So thank you for being here, and thank you for being such a wonderful guest.
Thank you. Thank you for hosting me today. Thank you so much.
Absolutely. I can't wait. I don't know when it'll be, but I can't wait till that day that we finally get to meet in person.
One day, hopefully.
All right. Take care.
Bye bye.